are back with the Amplify Sickle Cell Voices Week 2, and today's topic is newborn screening. So with us, I will hand over to the main guests on the panel today, but before we do that, just give you a little overview of why we're doing this and why we're doing it on behalf of Australian Sickle Cell Advocacy. Firstly, for those people that don't know me, I welcome you to this series again. Thank you for joining us. My name is Agnes. I'm the co-founder of Australian Sickle Cell Advocacy. And just thank you again for those people that have registered and everybody watching us on Facebook. This is so exciting for the sickle cell community, and we're so excited for you guys to join us tonight. So today's session, as I said, is another very important topic in the sickle cell world, newborn screening. As we stated last week, the series will be held weekly up to the 26th of September, and thereafter we'll start on every fortnight until the 10th, until the 9th of January, sorry. Then we'll have 3 sessions in between for the French session. The first session will be on the 3rd of October. Before I go ahead, I would just like to acknowledge the traditional owners of the land on which we meet, even if we're doing this virtually. And I would like to pay my respects to the elders past, present, and emerging. So, as I said before, we are doing this on behalf of Australian Sickle Cell Advocacy. And for those people that have watched us before, we always take this opportunity. We are using this platform for Australian Sickle Cell Advocacy. We take time just to tell you a little bit about our organization. So last week, I quickly did an overview. I'm doing something different today. I'll just do a quick presentation. I've got very few slides. I won't take so much of your time. So I'll just share my screen and tell you a little bit about ourselves before I bring the main people that are going to present the show today. So as I said, we are Australian Sickle Cell Advocacy, a not-for-profit organization. We started our work in 2014 over social media, and we registered our association in 2018. And here we had today, almost 2 years later. We are so excited and what we've achieved in the past 2 years. Our governance structure, we are governed by a board with a board of directors, and our chairperson, interim chairperson at the moment, I was just with her a few minutes ago, Dr. Margaret Evans-Khalil. And we have scientific advisors, hematologists, and people from public health as part of the board. Natalie, who's also on the panel today, she's a board secretary, and my husband is a co-founder of the organization. We are run by an executive team here in Victoria reporting to the same board. But if you can see this map, you see that we are represented in all states in Australia. We are in Western Australia, South Australia, Queensland, South Australia, New South Wales, and here in Victoria. We've got representatives in the Northern Territory and in Canberra, which is the ACT. Canberra is the capital of Australia. We don't have a non-patient yet in Tasmania, but if you're watching this and if you know anybody who's affected in Tasmania, please let us know so that they can connect with us. We're a big family and we like to have everybody on board. So our main objective for us, the most important thing is for us to support people who are affected by this condition, because this is where this organization is based. That's our foundation. Because we didn't have a few people that started this organization, we didn't have support, and that's why we're doing this. We do this observing our 4 core values, which we call them EPIC: excellence, perseverance, integrity, and caring. And you've seen that there's caring and perseverance because most of us in this organization are affected some way or the other, and we don't like giving up. We try anything we do, and that's why we put perseverance there. We try anything we can to achieve our goal. And quickly, why we're doing this, again, just emphasizing to the Australian population that if you look at this map here, the population of people that have migrated from countries where this condition, sickle cell disease, is prevalent, we are growing in Australia. And so we did this looking at the census from 1996 to 2018. We've realized that there's a need to advocate because sickle cell is considered a rare disease in Australia, and that's why we're doing this. So please get on board if you're affected, or if you don't have, you know your status, get tested and get in touch with us how you can do that. And then quickly, we just want to tell you that today we are going to do newborn screening as a topic today. What will be discussed here is for information purposes only. We are not giving any medical advice. If you need any medical advice or specific questions, please direct them to your hematologist or GP. So that's a little bit about our organization. But with the series, again, I'll tell you why we started this. Earlier this year, just like anybody else in the world, we were affected by the COVID, and our work usually involves us going into the community to do the work face to face, but we've decided to do our advocacy work using social media, and Facebook and Zoom has worked for us. So over the few months, we've been doing interviews, but we thought if we bring these people on board, we have advocates and caregivers and warriors and clinicians on this platform, over 40 people to come together. Again, it's just increasing awareness and education to the public. So we are simply using this platform after received good feedback from the series we've been doing since May. And our goal for this initiative is just to raise awareness and bring an effective action in place where sickle cell disease is prevalent. And that's why we're doing this, by bringing advocates, mostly past guests and collaborators, together to share the best practices and experience in order to advance the cause. So today's topic is important, especially to us as an organization. We, like other parts of the world, we don't have mandatory screening for newborn screening in Australia. That's what we've been advocating since last year. And our hope is for the policymakers to see this and people affected, the clinicians, so that they can help us with the cause, so that newborn screening is introduced in Australia, and we can't wait to get the advantages and how we can go about this. So that's basically what I'm here for. I'll go back and just be one of the attendees, and I'll give the chair now to Mariam and Kadi, who are the hosts today. And you guys can take it up. I'm so excited. Thank you for coming on board, and over to you. Thank you so much.
Thank you very much, Agnes. That was amazing. We're very impressed with everything you and your team are doing in Australia and all over the world, because you're not just touching lives in Australia, you're touching lives everywhere. Thank you very much for that introduction. First, I would like to introduce myself. Mariam Job from, I'm a Gambian, grew up in the US in Anchorage, Alaska, and I'm the founder and president of Africa Sickle Cell Support. We've been around for over 10 years, and our goal is to work with, as many organizations as we could across the world. And my co-host today is Katie Dean, and welcome to this special event today. Thank you everyone for joining us and, taking time out of your busy schedule, to be, part of this great discussion today. Katie, I will let you introduce yourself, please.
Thank you, Mariam. That was awesome. Hello, everyone. My name is Kari Dean, and I'm a Sierra Leonean Gambian / British. And I grew up in Sierra Leone. And in my early teens, I came to London. And I'm a sickle cell warrior. I'm a mother of a 13-year-old. And also, I'm an advocate for sickle cell. I have a small organization called Sickle Smart. We raise awareness for sickle cell here and in Sierra Leone. We do pilot schemes where we do screening to know your genotype. We have a campaign called Know Your Genotype campaign. And also I'm a independent travel agent as well, and an entrepreneur. So thank you, Mariam, for having me today. And I would also like to introduce Dr. Michael Budzi, who is joining us today from Cameroon. Can you introduce yourself, Doctor?
Okay, thank you very much for the floor. Thank you everyone for being here today. It's an honor for me, and I'm very, very happy to be on this platform. As you already said, I'm Michael Budzi. I'm a young medic. I live in Cameroon. I live in Yaoundé precisely. And I've been practicing with the Cameroon Baptist Convention Health Services for 3 years now. Quite an early career, but in this short time, God has made me to understand that I can get passionate about something, and I've gotten passionate about working with those living with sickle cell disorder. It's not clear how, but over time, I've become very, very passionate as I work with people and different people challenged by this. And I'm interested in research, especially in developing countries, low, medium income countries, especially my country first. I've been involved in a little research and I've been doing practice. And over time, I've worked with several warriors, close to 100 and more now. And I work closely with Are, the founder of Joy to Endure, a medical advisor of Joy to Endure. And through that, my passion keeps flaming, and I'm happy that I connected with Agnes, and through this, I've grown to learn a lot, and I'm here to learn and share what I know about sickle cell disorder and newborn screening. Thank you very much.
Thank you, Dr. Michael. That's a great work you've been doing. Thank you very much, and we are all pleased to have you here today. I'm sure you've got a lot of great things to share and experiences later during this session, and we can't wait to hear your amazing presentations to come. Thank you very much. Now I would like to introduce Natalie Capoua from Australia. Natalie, please introduce yourself.
Hi, my name is Natalie Capoua. So I am the board secretary of ASCA. Have been on this journey with Agnes for a number of years now. And it was really born just out of a need to provide more awareness and advocacy support to people who are affected by sickle cell disease. Not only here in Australia, but all over the world, and especially looking at Africa, where a lot of people are affected. But then with our experience in Australia, sickle cell disorder is seen as a rare disease, so that is quite a challenge as well in itself. There have been some positive experiences, but we also have a long way to go. It is positive, and yeah, it's great to be able to share our platform with everyone and to collaborate, and hope to further this along. Yeah, so thank you.
Ready?
Thank you very much, Natalie. That was great. I would also like to introduce Lashade Scott. Lashade, can you introduce yourself, please?
Yes, I'm the Sickle Cell Project Director and Newborn Screening Coordinator here in the U.S. In the state of Ohio. I am also a mother of 2 sickle cell warriors as well. So I see things from both points of views, from a healthcare professional and as well as a mother. So I'll be able to share any of my expertise on that during this panel discussion.
Thank you very much, Lashade. I'm really interested to hear more from your experience being a mother and being in the healthcare field, especially being a director for a sickle cell project. That's huge.
Yeah.
That's what we all standing here for, and that's why we all here together. So I can't wait to hear your stories. I'm sure it's going to be very interesting. Thank you very much. And now I would like to introduce to us one of our teammates here, Mariam Zuma. Mariam, can you please introduce yourself, please? Mariam, are you there? Hello, Mariam. Seems like we lost her. I'm sure she will be back soon. But thank you very much.
I'm here. Sorry.
You are here?
Yeah, I'm here.
Okay, please introduce yourself.
It's the internet.
I'm sure we can manage it.
Hello?
Hello, we can hear you. Can you hear us? Seems like we're having network interruption right now. Do you guys think we should have her come back up when the network is better so we can proceed and come back to you, Mariama? If you can hear us, once we have a break again, you can happily come back and introduce yourself, okay?
Hello, I am
Can you hear?
Hello.
Yes.
Yes, I am Mariam Zuma. I am from Sierra Leone, and I am a parent of a warrior who passed. And I am also working, which was founded by Adidin, who is one of our speakers today. I am AS. My husband is AS. Lucky to have a second child who is not SS. Thank you very much for bringing me.
Hello, Mariama, are you there?
Yes, did you hear me? Yeah.
Yes, we heard you. We heard some of the things that you said. I'm sure it's the network.
Yes, a network. I can hear of you clearly also. I just introduced myself. Did you get that?
Yes, we got that, Pat. Thank you very much. And I hope the network gets better so you can participate more. I'm sure you have a lot to share with us all. Thank you very much. I'm sorry, everyone watching. We're having some network issues today, but I would like to say thank you, Mariama, for trying to introduce yourself regardless of the network issues. But we'll go for it, and I would like to introduce Dr. Michael Batsy. But before we go on our discussion, for him to make an introduction, I would just like to point out some new key topics that we will be, doing our discussion on today, which would include the importance of sickle cell disease and newborn screening, the strategies for sickle cell disease, newborn screening, follow-ups for case management on newborn screening, screening devices available for newborn screening, and prenatal diagnosis. At this point, I will hand over to Dr. Michael Batsy to give us an overview on newborn screening on sickle cell disease. Over to you, Dr. Michael Batsy. Please take over. Your line is on mute.
Oh, thank you very much.
You're very welcome. It's okay.
I'm going to be sharing my screen. I will test it and see whether I can. Oh, the host. I see the host disabled participant screen sharing, so it seems like I can share my screen. So I don't know.
Apologies.
Agnes, are you with us? Can you permit me to share my screen? Okay, thank you. Since Professor Baba joined us. Okay, can I go ahead?
Please, the floor is all yours. We're listening to you.
Just acknowledge Professor Baba is here.
And that's what I was asking, whether I go ahead or he should be.
Oh, okay. 1 second, please. He's coming back. Okay, we had one of our special guests today, and we will, he just, logged on, and I would like to take time to actually introduce him. Professor Inusa Barbara, thank you very much for joining us today to be part of this great history that's been created by the Australian Sickle Cell Association, Agnes and the team. We're very happy to have you here today, and we can't wait to hear from you what you have in store for us. But for now, we have Dr. Michael Ibusa to give us a presentation on sickle cell disease and newborn screening. Thank you for coming, Professor Inusa Barbara. You're welcome.
Thank you. It's a privilege to join you. Thank you.
You're very welcome.
Okay, can you see my screen?
You can see it.
Okay. So I'm going to be, I'm honored to be given this opportunity with my experience to throw some light on this important subject, newborn screening, which we know is one of the core interventions and is one of the basics of optimal care of those living with sickle cell disorder. So in my brief presentation, I'm going to be giving an overview, the generalities, and I'm going to talk about the case of Cameroon where I live. So as I said earlier, I'm Michael Buti. I'm a general practitioner. I've been practicing for 3 years now with the Cameroon Baptist Convention Health Services, with a keen interest in child care and those living with sickle cell disorder. So coming to the basics, newborn screening is actually testing babies in the first days of life to identify disorders that can hinder their normal development and affect their long-term survival or health. And in other terms, it's a public health program screening, which entails screening infants shortly after birth for conditions that are not clinically evident in the newborn period. So it has to do with detecting early a condition that may not show any major signs at birth and intervening early. So early are the key words. And in the long run, ultimately preventing disability and death and enabling the child to reach full potential. So what we know again is that several developed countries routinely screen newborns for a battery of disorders. Is region and country specific. And like, for example, though I don't live there, but from my little research, I know in the United States of America, newborns go through 3 screens. The heel prick, like blood is collected from the heel. It's called a dry blood spot, and they are screened for several metabolic and genetic disorders, including sickle cell disorder. They're also tested, they have a hearing test to test whether they have any hearing loss, and they go through what is called pulse oximetry to check whether they have critical congenital heart disease. So I decided just to give a little statement about the history of newborn screening. I think it's interesting to know that Dr. Robert Guthrie is called the father of newborn screening because he developed a blood test in about 1963 that could detect whether newborns had the metabolic disorder called PKU, phenylketonuria. It actually is interesting to know that he had a niece with PKU diagnosed at 15 months when complications were already present. And just a bit about this, phenylketonuria is actually, people with phenylketonuria cannot process a certain protein called phenylalanine. And it's found in most of the food we eat. It's found in food, and if this unprocessed protein builds up over time, and if it's not intervened early, it actually causes some brain damage. So if you look on the left side of my slide, you see some an example of these 2 siblings. One is 11 years old, the other one is 2.5 years old. The 11-year-old male was diagnosed a bit later in life, and he already had profound disabilities. But his younger sister was diagnosed from birth and was treated with a simple diet intervention to modify the diet and a formula, and she shows no symptoms of PKU. So coming to sickle cell disorder. Sickle cell disorder, why are we talking about newborn screening here too? Dr. Annette Akinchete spoke last week broadly about this, but I'm just going to highlight some things about the generalities. It's among the commonest inherited disorders, and it's recognized by the World Health Organization and the United Nations as a current global health problem. The World Health Organization estimates that approximately 300,000 children are born with sickle cell disorder annually, and about 3/4 of them live in sub-Saharan Africa. Morbidity and underprice mortality related to sickle cell disorder in sub-Saharan Africa is still an issue. And meanwhile, outcomes have shown to improve progressively in higher income countries by implementation of early preventive measures and early institution of comprehensive care. And see, I highlight the word early because that's what newborn screening is trying to do, intervene early after we make a diagnosis. So I showed this diagram trying to highlight the importance or the benefits of newborn screening in sickle cell disorder. So we diagnose or detect the condition early, sickle cell disorder, after testing, and this causes us to commence preventive measures early, like the initiation of prophylactic antibiotics and antimalarials where necessary, like in my area where we are living in an endemic region. And we start vaccines. All of these are to prevent infections, which are a common cause of hospitalization and death in infants in sickle cell disorder. And also we recommend comprehensive care. Includes parental counseling early, follow-up, and even doing investigations that can help us to detect some complications or those who are at risk of having some complications like the transcranial Doppler ultrasound, which is recommended in my setting to be done from the age of 2 to 16 every year to detect those that may be at risk of having stroke and sickle cell disorder. So on the other hand, this screening also is important because those who have normal results, the families of these newborns can be counseled, sociogenetic counseling for these families. So for the components of newborn screening for sickle cell disorder, the components are similar in different settings, but the logistics, the testing methods, and referral policies may vary over countries and newborn screening programs. So the components are education, screening, short-term follow-up, and confirmation, that's the diagnosis, management, and long-term follow-up. So highlighting a bit about the screening, as I talked about the blood spot, dry blood spot is collected by heel prick to what is called the Guthrie cards, named after Dr. Guthrie, and it's usually between 724 to 72 hours of birth or before discharge from the hospital or birth facility. So the dry blood spot is transported to a designated laboratory based on the program or depending on the hospital. And the testing methods that are recommended are the isoelectric focusing IEF, high performance lipid chromatography, HPLC, and capillary electrophoresis. But it's important for me to note that recently some point of care tests like the hemotype SC, the sickle scan, have been tested in some studies for newborn screening with comparable results, though it has not been done on large scale. So there's some studies done in India and Nigeria, as I've quoted below. So in short-term follow-up, those who have a presumptive positive screen, their results are submitted to the hospital, the physician, and the designated newborn screen program. And those with the abnormal or unusual screen results require a follow-up of this screen with a confirmatory testing protocol. So that's when the diagnosis is actually made. So the screen actually separates those that may have condition and they have to confirm this screening result. So eventually these children, if it is confirmed, they are linked to sickle cell disorder clinic, physician, hematologist for comprehensive care and follow-up. The steps may seem straightforward, but the implementation is challenging most times, especially in settings when it has not been started. So it entails finding the family, educating the family, linking to medical care, and even continuing care, building the community's awareness about the importance of this data collection. And there are multiple players involved: parents, families, the birthing facilities, healthcare providers, laboratories, insurance companies, private partners, community stakeholders, and policymakers are central to this. So coming to where we are globally, we know that newborn screening for sickle cell disorder and other disorders is practiced in several developed countries, but unfortunately it's relatively new to Africa, where sickle cell disorder hits more. There are multiple hindrances, we cannot list all here. There's technical hindrances like absence of well-functioning health insurance schemes in our setting, the cost around this, the ability of policymakers to place sickle cell disorder as a priority public health issue, or even place newborn screening as a priority public health intervention. So it's also absence or lack or paucity of data to support the implementation in our setting in Sub-Saharan Africa, because we don't have a huge database with support the implementation of this. So most newborn screening programs in Africa have been in form of pilot programs, like Ghana has gone, it's one of the top countries that have done some pilots, Burkina Faso, Benin, Congo, Nigeria, and in Cameroon, I know there's a pilot project which I'm going to talk about shortly. But one thing we note about this is that most of the pilot project programs have been limited to specific regions or facilities, but have not really been translated yet to sustainable nationwide programs. So in my case here, as I conclude, Cameroon, some local statistics to generalities we know is that there are approximately 6,000 babies born each year with sickle cell disorder. And it's estimated about 1 to 2% of the population have sickle cell disorder, about 20% of the population having the trait. So newborn screening is actually a pilot project that is supported or funded by a French organization called EACD, as the French Development Organization. It was launched in 2015, in June 2015, and the goal of this project is to improve the care of those living with sickle cell disorder in Cameroon. The main strategies have been newborn screening in select birthing facilities, training of healthcare personnel on sickle cell disorder care, and raising awareness among youths. They have local partners, which include the Ministry of Public Health, Centre Pasteur Cameroon, which is a reference laboratory, and the research group on sickle cell disorder in Cameroon. So far, since June 2015, 7 hospitals have been involved in this pilot project. But the interesting thing is that these hospitals are only in 2 regions out of the 10 regions in Cameroon, and they're in the administrative and commercial capital of Cameroon, Yaoundé and Douala. So far, 58,000 babies have been screened, and we do about 1,200 tests per month. It takes averagely 7 to 9 weeks before sample collection and return of results. So my last slide, I'm sorry, this slide is in French. I just got that from the project writer from the project document, and it's actually in French. It just shows that the steps that are taken in screening after education of the parents and getting their consent. They take samples, then these are entered into a database. The results are the tests samples are analyzed, and the results are entered into the database. The results are collected. In step 5, those who have normal results or have the trait, the results are sent that are called and they're contacted through their facilities, and the results are handed over to them and their counsel. Then for those who have abnormal, unusual results, they are called for a complementary test. And eventually these children are linked, those who are confirmed are linked for comprehensive care through the partner facilities. And so far the project has been, since 2015, all those who have been diagnosed, 288 children who have been diagnosed with sickle cell disorder since the start of the project through this scheme have actually been followed up. They have free consultation and medication covered by the project scheme. A few of them have been lost to follow-up. 210 of them are still undergoing follow-up. So I think that's where I'm going to end. I always like to end by this slogan: I am, you are, we are sickle strong.
I'm a pediatrician and I lead the sickle cell service at Guy's and St. Thomas's in London. And I'm also the national chair for national hemoglobinopathy. Hemoglobin in England. So I chair the national panel, which includes sickle cell disease, thalassemia, and other rare anemias. And I also am a member of the American Society of Hematology body that actually is working very hard to try and support newborn screening for Africa. And currently we are able to, 5 countries have been approved: Nigeria, Ghana, Kenya, Tanzania, Uganda. How many is that? Is that 5? Actually, and Zambia, so 6. One of the other things that I'm involved in is trying to develop newborn screening for Africa through the American Society of Hematology. And those services that I mentioned have been approved. And we have a protocol that we're working at, and the main aim is that those programs will then kind of expand and include the rest of the countries, but also the rest of Africa as well. And actually we're thinking about also French speaking Africa, which has been really not included in the initial phase, but currently I know that DRC Congo and others are actually coming on board. I also am a member of the British Society of Hematology, and we also trying to support the newborn screening for Zambia. And we actually meant to visit Zambia in June, but did not go because obviously of COVID. We're still kind of working together to try and run that. But today, I really acknowledge what Mike had spoken about, so I don't need to kind of go into any repetition, but I'm just going to probably tell you a bit about some of the projects that we're doing to try and really how we can support some of the things that he mentioned in terms of the data and in terms of actually sharing of best practices together. So this is a European funded grant, and it allows us to work with African countries as well as 8 European institutions, and now going to increase it to be 12 European institutions. But it's actually to support capacity building in terms of individual capacity. So these are really aimed at kind of supporting staff in various areas, including from research to research management to academic. And so individuals travel between Africa and Europe and spend between a month and 12 months, and they are funded by the EU to do that. And accordingly, those are the institutions that we have in Nigeria, Kenya, and also Lebanon. And so this program started in January 2019, and we aim to okay. So I will come back to this slide, but the main aim of the program is to establish interagency and multidisciplinary staff exchanges across these institutions, allow us to. That's wrong. Okay, so am I the host then? So I can actually mute other people. So I'm going to do that. I'm going to mute other people since I am now the host. So I'll just go to participants. Good. Okay. All right. So I will also try and again share my screens when I'm able to get that. Okay. So the objective is to be able to really share best practices in newborn screening, and also to support the development of patient cohorts. So for example, like the cohort that Mike talked about, we want to see actually we can use that cohort to really develop in terms of databases, registries, and also to support biorepositories. So thinking about a newborn screen that have actually happened in the past. So if you look at this screen that I've showed, is comparing, this was a meta-analysis done by my MSc student, and looking at newborn screening programs and comparing the outcomes and comparing the mortality. So if you look at this one, the top one was the one in London, Southeast London, and you can see the mortality, if you look, any figure on the left is better and on the right is worse. So if you look at the one in London, where 99% of the babies that were born actually grow to be, survive into be adults, whereas in the American one, which is by Queen, 94% actually survive to be adults. So if you compare that with the one in India and the one in Jamaica, you could find out that the difference is obvious. And also when you then look at the rate of infections, the one again in London had the least number of deaths, but actually, so the one Rahimi is the one in Benin Republic, and I think Mike also mentioned that program. That program actually is very mature and has done a lot of program. So you could find out that the outcomes are actually very different according to the different sites. So is there any way we actually can share best practices? Also in terms of lessons, because if people have had challenges, it's good for us to know those challenges and how we can learn from those challenges and actually make sure that we can develop those projects. So this project is actually to help strengthen a number of aspects of managing sickle cell patients in using implementation science, but also in using e-health technologies. And we're actually trying to see how we can actually use e-learning platforms to support the programs. But also I'm working with the Royal College of Pathology and also INSAM. INSAM is a kind of a large institution in Paris, in France, actually, so includes some other towns in France. But actually, the Royal College of Pathology in the United Kingdom have been driving this initiative, and actually we have been able to develop assessment for gap analysis and actually going ahead to try and support those labs in developing their technology and their equipment and so their lab practices. So one of the things that Mike mentioned was obviously the different types of diagnostic tools. The isoelectric focusing is probably going to be a bit cheaper compared to the HPLC, which is high performance liquid chromatography, which we actually used in 2009 to 2011 in Nigeria, in Kaduna State, Katsina State, and Abuja. And also but that's very expensive. But the IAF now we actually have it also kind of installed in Kaduna, and I two equipments were actually offered to some states, Oyo State and Anambra State in Nigeria. Those are yet to actually come into function. And then following the project that we did in 2009, and using the HPLC, one we did in Kaduna and Abuja, the federal government actually decided to install HPLC equipment in 3 centers. But again, that is something that is for another talk, another day. And so this project allows us to develop a laboratory capacity, but also allow us to kind of develop counseling and managing of patients with sickle cell disease and actually screening them, but also looking at how to actually look at the epidemiology and the disease burden. But actually, work package 6 is to train in clinical research, and we are supported by the London School of Hygiene and Tropical Medicine. So yeah, Anita, I will soon finish. When I finish, I can answer some of the questions. In the terms of some of the things, I think ethics is very important, and it's something that EU really take very seriously, and actually want to make sure that. So we have people that actually can move to different places, but unfortunately, because of COVID, again, what did we do? Everything stopped. But we had some people who had actually traveled to London, they couldn't go back. So they basically continued in the program. 4 of them, they're still here. They still can't be able to go back. But actually, what about the other that were supposed to come? So we actually decided to develop a virtual platform to actually help people in terms of training, do some teaching and some lectures, and actually including a epidemiological program that actually we've been doing. So we are doing virtual training, webinars, daily contacts with tutors, and actually we really, so obviously either daily or weekly depending on the availability of those tutors. So we're trying to see how we can continue to actually the work even during this period of the COVID-19 pandemic, but also to support the research that people are actually doing, so we can continue to work on systematic analysis and some other things as well. So this is just some of the infrastructure that we're trying to kind of develop to make sure that we're able to work on the different work packages. And remember, I showed you initially the work package 2, work package 3 is a laboratory, work package 4 is newborn screening, and something like work package 5, for example, looking at the epidemiology and communication. And so we have delivered a number of lectures, and these lectures are in different areas: ethics, research, implementation science, epidemiology, counseling, laboratory sciences, neuropsychological assessment. And actually, we're just trying to make sure that we can offer people credits for actually doing these programs. And we've done quite a lot of these lectures. Now we're actually currently reviewing the impact of the program. So you can see some of the countries that have participated, even countries that were not part of the program have actually participated in this kind of lectures. So we are reviewing it and see how we can actually make things a lot better and really make the lesson actually quite long lasting. And so this is some of the feedback that we have received, and we continue to work on those feedback to try and make things a lot easier for people. So so one of the things I wanted to just kind of emphasize is that a lot of programs are actually going to Africa, and it will be very helpful if we can get all of these programs come together and actually share ideas, but actually really benefit the countries. And I think the people that are very able to do that will be especially the people in the country. So I'm working with people in Zambia. Because of the work that we're doing, actually we bought an equipment to Ndola, Arthur Jefferson Children's Hospital, and their TDRC, which is the laboratory aspect. It's an infectious diseases lab, but actually is very well resourced, quite competent. So we're working with them to actually try and develop the program in Zambia. So my current role, I have a specific role in Nigeria, specific role in Zambia, but actually on the general role in the whole of the African program that is driven by American Center Hematology. In this ARISE project, which I have just kind of talked about, I've mentioned the countries that are actually kind of participating, but actually at the moment, a lot of people are actually benefiting from the program because of the COVID pandemic. I think newborn screening, like Mike said, is essential. It helps actually develop skills, but also it helps you as a platform to actually kind of help in supporting counseling and also education for patients, for the community, and also for the policymakers. How do we kind of transform the newborn screening pilot into practice. I think that's one of the things that we're trying to use implementation science to allow us to make sure that all stakeholders have a role and are able to actually make sure that the program that are developing, that they can support them going forward. So thank you very much, and good afternoon or good evening, depending on where you are.
Thank you,
you
Professor
very
Baba.
much.
Okay,
Oh,
okay.
Okay, thank you very much, Professor Barbara. That was a very insightful and informative presentation you just did. And I must say that I'm really impressed to hear all these great things that, you and the team and the individuals are working on. And we'd love to hear more about what, more in-depth information about the programs. But for now, I would actually move to Katie, who has substantial background and wealth of knowledge in sickle cell disease, to elaborate more on the words and key terms that have been used in this previous presentation. Katie?
Right, great talk here. Professor Yunusa Baba, thank you very much for that wonderful presentation. I would really like to know more about the projects that you're doing, especially the ones in Africa, because I have a small pilot scheme that I do in Sierra Leone as well on screening, or if it's a Know Your Genotype campaign. So maybe we could share notes on that. Right. Sickle cell is a non-racial, economic, or geographical disease that affects only certain understanding and acceptance in society. I'm going to open this to the floor to the panelists, Mariam Zachary, Mariam Zumbo, Natalie, Dr. Michael Budzi, Lashada Scott, and Professor Unuzu Baba to pay attention to and see what you understand from the newborn screening that was just shared. Do you have any questions? Any questions from the panelists?
At the moment, no questions for me. It was really a great presentation. Although, just a question for Dr. Mike. Can you just tell us that pilot screening program, just to clarify, that's only happening in Yaoundé and Douala, you mentioned?
Yes, that's correct. So the project leads, they chose these sites, and that's where it has been happening only. It started only in Yaoundé in 2015.
Okay. 2015, okay.
Yeah, 2 years later, Douala was included. I know the reasons, but they chose that. So far it has been happening, and hopefully they would, I think they plan to expand, but so far it's been only in those 2 regions of Cameroon.
Okay. Okay. And what about people outside of those 2 regions? Are they able to join the program should they wish to, or can they be referred by the whoever is looking after them in terms of medical care?
Actually, the deal is those that benefit are those who give birth in the partner facilities. So if you benefit, you will give birth in those facilities. So it's even complicated because I don't work even in a facility that is linked to that. So sometimes I've asked, most of this is based on research and communication with the project directors. So I get this information, and some of the parents, if they're really interested in counsel, they will go there and give birth. A few of them, like I was talking with the project director recently, he told me that a few parents, like in the first few days, in the first 28 days, if you tell them there's one of the sites where they can test the children just a few months, even if they give birth somewhere else, but that is not yet too official. Okay. So I think it's a plan for long term. But so far, it's only those that give birth in those facilities, and that's one of the challenges because we are in the urban facilities. That's where it's really those in Yaoundé and Douala that are benefiting, but in other regions, they are not really benefiting.
So my other question would be, okay, especially if the ones that are privileged to participate into this program are the ones who actually have their children in these partner facilities. Are these paid facilities? I mean, how do they, because I'm sure that also widens the gap on the access to that type of screening. And so forth.
Yeah, I think very well. They are paid facilities, and even more like I don't know how the project chose the facilities, but these facilities are paid. It's true that the children, when those that are diagnosed, are actually linked to pediatricians and sickle cell disorder follow-up programs, and they take care of the follow-up from then on. But they take care of their bills during delivery and everything, and their paid facilities actually widens the gap, and it's challenging so far. And so these are just pilot programs, and they have chosen where based on maybe on some agreement, so where they want to carry out their project. And that's why I think Professor Baba talked about pilots to practice, to becoming expanded or becoming involved, other facilities getting involved in this, because just to select few, and we don't know how to select few benefits.
Okay. Just one
Can
more
I have a question then? Oh, sorry, go on.
Okay, just one more question and then I'll be done. So just one more question. One thing that you have mentioned that we know is the scarcity of data, particularly in sub-Saharan Africa, when it comes to SCD, screening, management, and so forth. What type of data are they actually looking at generating? Because I understand that from what you've said, from the PowerPoint slide that you shared, there is definitely capturing of data.
Yes, there is capturing of data, but relatively it's less compared to, we need to have, there are different programs. I think Professor Baba talked about different programs doing a lot of work. But sometimes this data, if I go online and I want to check for data on sickle cell disorder in Cameroon, it's actually very scanty. There are programs, but even the basic data about prevalence, I think this prevalence that we have is estimated. There's a lot of estimates that we are giving. We don't have any clear, direct figures that are based on large-scale studies. These studies were based on, if we do this newborn screening in Yaoundé and Douala, and we use it to generalize for the population, it's not true. So we have to be able to do a large nationwide program, and that's what has been done in many places. We don't have nationwide prevalences. We don't have. It's not very, very available. Otherwise, relatively, it is scarce. Yes, okay. But it's not as if there's no data.
Okay, thanks. So I'm hoping that my next question will be directed to Dr. Inusa, and maybe he can answer on how data modeling will be happening in Africa, across all of these pilot programs. So I'll leave that.
Okay. Okay, so I can respond to that. And that's why I mentioned about a number of initiatives that are actually aiming to build infrastructure in Africa. And data is actually very key. So there is what they call Sparkle, which is funded by the NIH in the US, and the coordinating center is in Tanzania, but they also have hubs in Ghana, in Nigeria, and actually in South Africa to support data. They're using at the moment the red cap to try and help develop electronic data systems, but also you could use paper copy and then kind of be transferred back to the various data. And we've been working very hard to make sure that the data elements are actually very similar, but also very relevant. Because if you go to, for example, like in Ghana, and you want to find out about the mother, that will be basically you find where the patient is. And you go to Nigeria, maybe the father, but actually you need to think about when you go to a community, how do you find a patient that you've screened? Because I noticed from my figures, they've screened about 58,000, but I noticed that they have only 288 patients with sickle cell disease. And that's a very low prevalence. That, except it probably what happened is that maybe you don't have all the babies that actually you've diagnosed, because the prevalence for sickle cell or incidence in the population in Nigeria is between 1.5 to 2%. And that is similar to across a number of the African countries. So that would have been quite a lot of patients if you had done 58,000. So, but I'm not sure whether probably they didn't have a number of them. But in terms of data infrastructure and data training and data support is actually very, very key. So the data that was used in Ghana, we also used as a template to try and make sure that the data is consistent and actually also allow you to find the person that you tested, because we did have problems before. We screen in Casina and sometimes it's difficult to find out where the baby is. So you screen them, you need to make sure that you can get the baby, get to the right family, and if you miss the family, then actually that will be a disaster. So we did that screening, and actually we reported later on. I mean, we'll have some kind of publication as well. But I've added our website just on the platform so that people could share that, because you can get some of the work that we're developing. I had a question. So my question to Mag was, did they get all the babies? Because if they screen 58,000, then obviously they'll have much more than 288. If you use the prevalence of even like 1%, it will be much higher than 288. So do you have any idea what happened to the rest of the babies that were screened? Because screening is important to make sure that you can get the result.
Yeah, I think this 288 gives roughly about 0.8. It's not a clear, it's not giving around 1 to 2. So I actually, to get this information, I talked to project director. I'm not directly involved in this project, so I cannot answer technical questions about it. But I know based on their reports, they say they follow up all these children, they send SMS, but I'm sure there are some loops. So that's what they report, and that's what is given as the report from the screening so far since June 2015. So I cannot answer technically about what happens, whether they have had any loops, because they have not. They reported only the loss to follow up from screening to follow up so far.
I have a question for Dr. Mike. What type of test do you use when you're in the field where there's no lab facilities?
Okay, here, that's not like this program that I talked about does not go to the field. So far, they have been using only the isoelectric focusing in the hospital setting. It's true that some people have done laboratories, community, very little screening projects with the sickle scan, but no one has done any large scale that I know of here with, yes, I think we even carried out one in our facility here in the Cameroon Baptist Conventional Health Services, one of the facilities. We use the sickle scan, that's community, but for this newborn screening, I've not heard, none of this program does not use that, so it uses the isoelectric focusing.
Right. Do you find the sickle scan kit very how can I put it? Is it very accurate when you test, or do you have to test the babies again?
Mostly, I think the reports that the sensitivity is close to okay, and most of the people, most of what I can say is based on studies that I've read by hemotype SC and sickle scan, but there's nothing that has really validated that for use here for diagnosis. So most of the time, you can use that to screen, but I've not had any clear indication about that being used for diagnosis. Yeah, so, but the reports, when I read the leaflets and I talk with the sickle scan delegate, talking about the fact that it's close to okay. And most of the children that were screened positive from the sickle scan during were confirmed with another test and it was positive. Were confirmed with the capillary electrophoresis and it was okay. So it shows that the sensitivity is almost comparable.
So if I can comment just about the this point of care testing, there are quite a number of them. Hemotype C had been tested in Nigeria and also done in Uganda, and actually the and they did report, they put very, very high specificity and the fact that it is very closely linked, and in fact Obi is very strongly in support. I'm talking Dr. Onodu from Nigeria. She feels that the point of care testing actually is very close to the HPLC, and so this has been published in a number of papers, and one of the things that I think it's important to recognize is that there are also issues in the sense that if you test a baby at birth and you have the result in front of you and the mother, are you prepared? Is that mother actually ready to receive the result? So those are some of the things that we need to make sure that if you can test and find the result straight away, are you prepared? Are you in a position to give that parent a result in a way that is going to be acceptable? Somebody who has just had their very newborn baby, very excited about a newborn baby, and you start breaking out the news. So I think there are a number of things that need to be taken into account so that we have a whole system, because the lab test is only part of the screening program. And the lab test, actually, you could have a lab test that is located just one in a whole large area of like 10,000, 20,000, 10 million population. You can have one particular equipment. You can transport those specimens to that site using the IAA platform, if you have the IAA platform or the HPLC. So I think the test is actually just one component of the whole program, because the major component is how do you actually get people to understand the result and how to implement the result and how to use that result for the empowerment of the people and the population to managing the patients. But one of the challenges we actually thought about is that we just don't want to we're going to screen in villages, we're going to screen in primary healthcare centers, but we need to train the primary healthcare workers to be able to give them first aid information. So like first line information about if they come with pain, this is what they should do. If they come with a fever, this is what they should do. And if they have severe complication, then they can transfer them to centers that actually could manage those conditions. So I think those are some of the issues that need to be in place to actually make sure that you begin to do the testing. But testing is only one component of the program.
That's right. Also, I think they need to include psychosocial services and counseling in these facilities where they do the testing, because it's not just, like you said, it's not just to do the test, but you know, you need to prepare the parents or the guardians of the baby, and you know, there's a lot of challenges that comes with that, especially psychologically and things like that. So I think it will be a good idea if they have like counselors or social workers, psychosocial.
Yeah, excellent. Thank you. Because what we, in 2009, we basically had equipment from the WHO about to start the screening and realized, look, we have to go back to the community leaders and actually tell them that this is the program we wanted. So we had to go and meet the village heads, the traditional rulers. And then one of the things that actually has been very useful also is to make sure that the psychology training is not only done by psychologists alone, but actually primary healthcare workers are taught to actually do this and handle it themselves. So I think this is some of the things that I completely agree. I think there's a hand from Zakaria. Zakaria
yes,
has a hand on.
If you allow me, yes, sir. I will say something in Arabic, then I will start because their Arabic is to my followers. الإخوان بس اللي دخل باسمي يريد يطلع لأنه صاير شوي عندهم misunderstand ويقدر يدش على الرابط الثاني. Regarding the screening, what we have in Bahrain, we do the comprehensive screening, like things to prepare before the blood test. It is costly, but the most efforts goes for educating the community and educating the care provider, because we want them to understand why it is important we do the screening and how much it will reduce and would save our cost and will improve the quality of life. And also to prepare the parents to what to expect. And it is not that only, it is to prevent these kind of marriages. And that's why we do 3 different types of screening, that in the newborn screening and in class 10, where at the school, where boys or girls to know their genotype even before to think about engage or to get married. And also before or pre-marriage test, that also to check the genotype, and the result, just to make them aware that what is their genotype, but it is not a must. I mean, law will not prevent this marriage, but we will counsel them, we will guide them. If they follow, we will appreciate. If they didn't, we cannot do things. Nothing, there is no such law to prevent these marriages. But even though when the blood test given or the we call the parents and we tell them what is the plan for what the expectation for their baby, and where they have to go, so they know where to go, what to do, and what to expect, and the complication, and also how to we call the policy makers on board to tailor some law or regulation to improve things like how to help these young kid to 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 succeed in the schooling, or to find or to help in the long term treatment, like the genome program, or stem cell program, or bone marrow transplant program. It needs everybody on board to help. That's what I was want to say.
So I was in Bahrain in February for the sickle cell conference led by the pediatric hematologist, and she presented how they have reduced the prevalence of sickle cell disease over, I think, a period of 8 or 9 years, and that was kind of big news. And then obviously, Bahrain, you had the capacity that your country is quite small, but actually I was very, very impressed about the community-based program, whereby there are people who are actually trained within the community to support the program. And currently, I know that Saudi, so what you are talking about is actually, apart from the newborn screening, the community screening in terms of looking at preconception and everything. But talking about the newborn screening, I know that Saudi are actually about to actually embark on a newborn screening program. So in terms of that region, there are, I think, newborn screening is still well behind. We still need to kind of see how we can actually implement it. And I know that the UK Sickle Cell Society have actually been involved with Bahrain Sickle Cell Society as well. So I think Bahrain is a very good example. Thank you.
Thank you.
Thank you very much. Anybody else has any questions? Anything to add?
Thank you, Katie. I actually want to bring Lashade. Are you on board?
Yes.
Okay, let's hear from you. Being in the US and being in the as a director for the sickle cell project, and you know, and being in the healthcare field, and as a mother especially, what is your experience like, especially with newborn screening? What is your experience like in that field?
So as I told you before, I am a newborn screening coordinator as well. Typically the babies here, every baby is tested at birth within 24 to 48 hours, as Dr. Mike stated, with the heel prick. And then they can opt out of that if it's religious purposes. But as far as I had seen in one of the comments, someone had stated something about a follow-up. For me, that's typically a challenge at times when the diagnosis comes to my office. It's getting the parents to come in, but COVID has had some advantages in that regard. And I mean, I hate to say it like that, but I've been able to reach out to families through via Zoom or telephone conferencing. So essentially, reaching out and giving them those diagnoses and giving them the education piece that they need to be able to properly take care of the child with these diagnoses, and knowing what's needed is kind of what I do in my role here in Ohio. Like, did that kind of answer what you're asking me?
Yeah, it does. And my other question to that part, the other part of to that question was that as as a sickle cell coordinator for newborn screening, what kind of question, like when the child is being screened, right? Is it like mostly that they don't know that their baby is gonna have sickle cell? Did they do prenatal? Like, were they aware of the situation? Were they expecting it, or they didn't expect? They didn't know what their genotypes were before conceiving or having that child? Because it could be two sort of reactions from two different angles, like knowing what your genotype is and your partner, and expecting that there's a 25% chance that the child might be a sickle cell trait or sickle cell disease, and versus for someone who didn't know what their genotype was, and it come off as a surprise. How does that come across? Like, have you guys dealt with situations like that?
Yes, I actually have, and even my own personal story. I'll speak on that first. So me and my husband were both born in Michigan, so it wasn't mandatory to test every baby to 87. I was born in 87. He was born in 86. So I knew that I was a trait carrier for sickle cell trait. And prior to us getting married and having children, I asked him, well, do you have sickle cell trait? So of course he said no, because he was never told that. So it took for us to have our son, who, when we found out, and I found that out over the phone, maybe like a month after my son was born, that he had sickle cell disease. So of course I felt, I was disheartened, because I felt like I did everything that I needed to do to prepare. So now that I'm in the role as the project director and newborn screening coordinator, I tell all of my patients to be tested prior to, because there's a possibility. So here in Ohio, it's not mandatory to test every baby to March of 1990. So anybody born before then, there's a possibility that they don't know their genotype. And then things just get lost in translation. Like, parents may not have told their child that they are a carrier of sickle cell trait. So I always suggest, I go out and I do a lot of outreach within the community to let them know, you should all know your genotype. You should just get tested. You can ask your primary care provider to run an electrophoresis, and they'll test to see if you have sickle cell trait. So with that being said, just being able, having to tell parents after reading their results, and they felt like how I did, like they did everything that they needed to do, and then they still ended up with a child with sickle cell disease. It's hard sometimes to be able to tell, to have those type of conversations, but I feel that the more we become informed on our status, we can, I don't want to say stop having children with sickle cell, but we can be more informed and more prepared in that regard.
Thank you, because that was one question I really wanted to, get answered for, because I do a lot of community health work in Oregon here with the Sickle Cell Foundation of America. And I've had patients that tell me, oh, their partner told them they were AA, and then they have a child, and the child is, and it has caused a lot of issues in marriages, because they would probably think that the partner lied to them, or they wanted to set them up for failure, because at the end of the day, it's the mother who basically automatically actually deals with all these, major challenges of, raising a child with sickle cell disease. Because my own brother, is a warrior. He's 15 now, but not that the fathers don't care, but, it becomes like an automatic work on the mother that takes on, the whole burden and the responsibility of, raising that child. Thank you. That was very informative.
No problem.
Does anyone have any questions? Well, I must say this was a very elaborative and very detailed.
I've got a question, sorry, from the chat box.
Okay.
There's a question directed to Dr. Inusa Baba. It says, are there any chances that a baby may be AA despite having an SS parent? It's directed to Professor Inusa Baba.
Which parent is own? No. The SS parent?
Yes. Is there any chance that a baby may be AA despite having an SS parent? That's a question from Chantel.
No. Do you want me to say more?
Yes, please.
All right. So I know, okay, I go through a lot of issues as well. So, and I think just from Lashade's point, I'll answer that question and this one. So is that a number of my parents, my patients' parents actually came from my country. And then one mother said she was given a result from the lab and she did it 3 times and she heard it from the lab. So she got married to somebody who was a carrier. And the first child turned out to have sickle cell disease. And the question is, how did it happen? So actually, it happened that the test, she was given a wrong result. And then another parent happened to have a beta carrier, a beta carrier, and didn't know that they have a chance of having a child with sickle cell disease. And the first child also had sickle cell disease. So apart from the fact, if you may have a beta carrier, in that case, you may not know you have a sickle cell carrier. But actually, if you have a confirmed diagnosis of sickle cell disease, then obviously there is no way that you're going to have, even after bone marrow transplantation, you cannot have an AA patient because the germ cells are not changed even after bone marrow transplantation. So, and that's one of the things we try to tell patients before they go through bone marrow transplantation, that your germ cell would not change even when you are cured of sickle cell disease. So, and you're going to have a child from your own eggs or your own sperm, you still have a transmit an S gene to your offspring. So so I think those are the things that we need to kind of continue to educate some of our parents. And some of the other parents is that you tell them that you have a 1 in 4 chance, and then they have a 1 child with sickle cell disease, and then they thought that's the end, and then they begin to have more children, and then they say, you told me this, now I'm having another child with sickle cell disease. So those are the point you need to kind of really take a lot of time to try and explain that it's a lottery for every particular pregnancy, and that lottery doesn't change. The short answer to the question is that it is not possible to have a child with SS. Obviously, you could do, you can do donated eggs and other things, which is something you could do actually. So we should look at options that are available to you to see maybe you can get a sibling donated egg or donated egg from somebody, but you will not have a child with AA. No.
Thank you for clarifying that, Mr. Baba, because I think for all the followers on our Asker page, please take that. We had a presentation about bone marrow transplant a few weeks ago, and just emphasizing the good point that Professor Baba has said. Once somebody has a bone marrow transplant, the genotype does not change. You don't become AA once you have a transplant. You're still able to pass on the gene. So that's very important to know. And yes, over to you guys. Thank you.
Thank you, Agnes, and thank you very much, Professor.
I just have one question for the professor. Professor Baba, in your experience, are you finding that are people also taking the option of doing pre-genetic disease testing in order to prevent the birth of children with sickle cell disease at all, especially you are in the UK?
Yeah, so one of the things that we have in the UK, which is difficult for me to offer to my patients and my clients in Nigeria, is that we offer them the prenatal screening, the prenatal. You're talking about, like, so we can do prenatal screening, but also we offer pre-implantation genetic diagnosis. But also prior to that, obviously the choice and other things which somebody had already alluded to is what you can give to everybody, that you know your hemoglobin phenotype, like Lashade said. But actually in the UK before, when they screen and you are a carrier, you were not given the carrier test status. So really you didn't even know whether you are a carrier. And the decision to actually give the carrier their status is actually a recent decision. So if you have your carrier status, then you can decide in terms of avoiding. But in terms of pre-implantation genetic diagnosis, the government funds, if you are both carriers and you don't have a child that does not have sickle cell disease, then the government would fund if you want to do pre-implantation genetic, which is basically like a test tube baby in terms of in vitro fertilization for a selected baby that doesn't have sickle cell disease. So it could either be a carrier or AA. But once you have had one child that between the two of you, as a father and a mother, you have one child that does not have sickle cell disease, then you will have to fund yourself. So yes, that is available. You can obviously, so what happened is that if we have a patient with sickle cell disease and the parents want to have another child, we actually could offer them the option of doing in vitro fertilization to have a baby that doesn't have sickle cell disease. And in fact, on top of that, we also could do a HLA tissue typing so that the baby that is born actually is a prospective bone marrow donor for the sibling that has sickle cell disease. You know, you can immediately feel and understand there's a lot of ethics issues and religious issues, and so things that you have to deal with yourself and actually come to terms with and say you want to go for. But I do have a number of my patients that they had very strong opinion. They didn't want to take that on, and then they had a child with sickle cell disease, and later on they changed their mind and they actually went for pre-implantation genetic diagnosis. Even the prenatal diagnosis, whereby they have a choice to not continue the pregnancy, even that crosses religious background. So that people that had a very strong feeling that didn't want to do it, actually when they have a child with sickle cell disease, some of them actually change their view and actually ask for that. So I think those are things that are very expensive if you're not kind of funded by the NHS, for example. And I think it's something we need to think about in terms of education for our families back in Africa.
Thank you very much. Do we have any further questions or need clarifications?
There's questions in the Q&A and the chat box. You guys can take over, please.
Okay, we have a question that says, are there any medical techniques that can help two people, AS and SS, from having SS kids? Is there any kinds of genetic modification that can be done? And I believe you just answered that question, if I'm right.
So did they say AS and SS? What was your question? I'm trying to look at the question now.
Are there any medical techniques that can help two people, AS and SS, from having SS kids?
So they are AS and they are, so the parent AS, so both parents are AS, so that's why you could do the pre-implantation.
And the other is SS. So they ask.
Yeah. Oh, you can do the pre-implantation genetic diagnosis and select the one that has a sickle cell sickle cell carrier, and that child is very well anyway. So if you could do that, I think. But again, it's so that is definitely possible. That is by doing that. Basically, select the egg that does not have the SS but that has the AS and reimplant it back. And that is the technology that is available. And I said, if you never had a child that doesn't have sickle, you can qualify for that as long as you're also less than 35 years of age. So that there are a number of catches there. So that's in terms of the free one. But if you have the money, then you can go for what you think you can afford to.
Okay. There's one other question one of our people, the audience have. It says a friend of theirs have 3 children born with sickle cell disease, and they have a 4th child who they fear taking for screening. They do not want to know the results. What advice would you give this couple?
So they don't want to do the result, or they don't want to know the result?
Because they already have 3 kids who has sickle cell disease, and the 4th child, and they have the fear of wanting to, testing the kid to know if they have a disease or the trait. So they kind of in the they kind of scared, sort of.
I think that is possible. So that's not actually uncommon. So one of my colleagues, my classmate, medical school, and then they saw their child began to have symptoms of sickle cell disease, and they didn't want to know that the child has sickle cell disease. It took them like 3 years to basically finally decide to do the test to confirm the child has sickle cell disease. So sometimes there's a significant issue of denial, and it's not easy for for the family. I think you need a lot of work, and that's why somebody talked about psychology, counseling. And these things are really kind of very key and very important. But we know that knowledge is power, and truly it is power here, because if, for example, you don't offer that patient some prophylaxis, penicillin prophylaxis, the normal vaccinations, then you're actually doing that patient a disservice. And a lot of people with sickle cell, I have friends, I have colleagues who have sickle cell disease. They are professors, they are doing whatever they're doing. So it's just to give you the best chance of survival and the best outcome you could do. So I think a lot of education is required in that situation.
All right. Thank you very much. Thank you very much, Professor Inisa Baba. Well, does anyone else have any questions before we move forward?
There's a question from somebody attending, anonymous. It says, in Africa, genotyping is something that is not very common, and most people get married without knowing their genotypes. So as advocates, what would you guys advise Africans and their governments to do to help curb the number of sickle cell patients? To Professor.
Before the professor jumps in, I mean, as someone who is definitely affected, I'm sure a lot of people here are, and just reading out all the challenges, I mean, knowing all the challenges that we currently have in Africa, you know, no data, obviously, yes, education could go a long way. At the same time, when we also look at predictions for the future, in Africa, it is going to, you know, if we don't take care of this issue, it is going to explode. So it is in our best interest to educate ourselves, to understand how this condition works, and to help prevent it. That's that will be my advice. Yeah, you know, and for the ones who are here, we can do more by educating ourselves. You know, we cannot neglect this. I feel that this is very much a public health issue for a lot of people, you know, so we just cannot afford to neglect it. That's my take on it.
Can I just add something? I mean, this is why I do the Know Your Genotype campaign, because I feel if people know their genotype, you know, it will reduce, you know, babies being born with sickle cell if they make, you know, informed decisions after their tests. And the challenge we have in Africa is most of these governments or the leaders in places, they don't want to recognize sickle cell as, you know, a public health issue. They will tell you, oh, sickle cell is not important. Oh, you know, we prefer to support cancer or diabetes or HIV. But when it comes to sickle cell, it's a very neglected condition. Nobody wants to, you know, help or promote the awareness. So
and I will challenge that as well, to say that, you know, you are basically missing out on a workforce because, you know, of the cost of sickle cell and caring for people who are affected by it. And, you know, they're just people affected by a condition, yes, like cancer and whatever. So they can be just as productive when they are, you know, when they are well, and it has been proven. So we just cannot afford to neglect this. We do need to get educated. We do need to have people understand how it works so that they can also live better.
And just to add one more thing to what just been said about creating awareness for the Know Your Genotype campaign, I strongly believe, as much as we want to campaign for the Know Your Genotype campaign, we need to push more into educating our communities as well, because I travel to Nigeria a lot. My husband is Nigerian. And when I talk to, you know, people about, you know, knowing their genotype, and most people actually do know they have sickle cell. Some of them, they have sickle cell trait, and they're dating someone who has sickle cell trait. And when I try to talk to them, you know, to see a genetic counselor, you know, talk to them, what are the chances of them having kids with sickle cell disease, they don't want to hear it. They say there's God. God would not let that happen. So as much as we want to push the newborn screening, we need to push harder on, you know, educating these individuals, make them understand and believe that this is real. It's not just science, you know, it's not just a white man trying or the black man trying to teach us what science is, you know, the scientific method of sickle cell disease. It happens, and they have children dying from sickle cell disease. And most don't even believe it's a sickle cell. They think it's something else. So like traveling, you know, in a couple of African countries and sitting with individuals, you know, talking about different experiences actually gave me another perspective of, you know what, this is not just one known day genotype. That's not just the problem. The actual fact is that these individuals do not, I'll use the word, do not really care about what we're talking about. They're more concerned about their needs and their immediate wants and needs at that point in time, but they're not thinking about the, you know, the circumstances that they're going to put themselves in and their children for the future. So we need to also, you know, push harder on teaching them, letting them know that this is real. If you know your genotype, it doesn't stop there. You need to make sure that you do the right thing. It's like steps. Like you have to follow those steps to, you know, for us to continue to eradicate this, because that's the goal. We want to make sure that there's a stop to this. There's an end to this. We don't want to lose any more babies. We don't want to, you know, we don't want to see, you know, the numbers going up or the mortality rate going up as well. You know, we want to make sure there's, you know, better access to healthcare, better knowledge. We're teaching people and giving them that education that they need.
And Mariam, if you don't mind me adding to you, I also feel like here in the United States, that's why I am so involved in educating the school systems, like especially when we're dealing with children that could potentially be childbearing. I think starting there first, like being able to educate in the school districts and letting them know the things that are associated with sickle cell. Like I said, I knew of sickle cell disease and I knew I had sickle cell trait. I didn't know everything that was associated with it until I had children of my own. So having that education piece with just the school districts would kind of alter a couple of these point of views as well.
You're very right about that. Totally right, because I went to middle school and high school here, and I've never learned anything about sickle cell. Everything I know from sickle, like I was shocked to know about sickle cell later on in life, like 4 or 5 years after high school or middle school, to know that these things exist and it's affecting me directly as an individual. So it's a no-go area, but there's a places that we should start from. We need to start from the grassroots, you know. The basics. Those are the basic fundamentals that we should actually really push a lot of energy, pump a lot of energy onto, you know, educating this individual, the younger people, you know.
Who is that?
Dr. Nasser. Hello.
Hello.
I'm from Bahrain.
Hello, Dr.
Sorry, this is first time I don't know about the title of this Zoom. But I'm a doctor. Sorry, I am from Bahrain, and actually I'm treating corona. I am sickle cell disease also. We have a lot of, I'm a doctor and I'm sickle cell disease. I'm specialized in corona. Nobody is specialized in corona, I know. But I feel myself like this because what happened to me is in the last 8 months, I'm from Bahrain. Bahrain is a small country. We have almost 1 million plus population. And despite that, we got yesterday 600 people every day, almost plus minus. Getting new cases of corona.
Thank you all very much. This is actually very inspiring. It gives me hope that, you know, the fight against sickle cell disease, we have great leaders, great advocates who are actually ready to help fight this disease. And we can do it. We can definitely do this. And now that this brings us to one of our last part of this this discussion today, is to hear if anyone has any misconceptions over time, or you've heard over time. I know we've actually mentioned a couple of things as such, but if any of our panelists actually have ever had any misconception or misunderstanding when it comes to screening, or diagnosis as well.
Hello everyone, how are you doing?
We're doing well, thank you, Aliu.
Aliu.
Hello team, how are we doing?
We can hear you, Aliu.
Yeah, okay, I'm here in Zambia right now. I'm going to do an interview about sickle cell. So I said before I go into the video, I just want to congratulate the team. You've been doing great. The program is so nice, organized. Keep it up. Keep fine sickle cell. It's a great job, and we're doing. So I want to thank you all before I get into the studio. Bye-bye.
Thanks, Aliu.
Thank you, Aliu.
Anybody has anything to say? We are almost on time, and
Okay.
sorry.
Hello. Yes, can I speak?
And this is Sam.
Hi, Sam.
Katie?
Hello, I think there was someone else who wanted to speak before me. They can speak, and then I'll speak after them.
Okay, let me finish first. I'm fine after I got hydroxyurea. Finish.
Thank you, Zakaria.
Just I'm a doctor, and I'm completely fine. I never had any single VOC. I became thin. I was obese. I was obese, 122 kg. Now I'm 100 and less. My total is 188. You can calculate the BMI. Anyway, actually, I'm very fine now. I'm going home tomorrow because I had just corona because of my job as a doctor. I'm going home tomorrow, and my wife is coming now. Thank you. Sorry.
Thank you so much. Thank you for joining.
Can I leave, or I should stay?
You can stay if you want. It's fine. We can stay.
Because I don't know what I want.
Okay, then you stay. We'll decide for you. Stay, please. Sam, go ahead.
Hi, Agnes. Sorry. Yeah, thank you. Thank you very much for this opportunity. I guess, so my name is Samuel Mbunya from Kenya, but I currently reside in Sweden. I've been involved in sickle cell for quite a number of years as in program management in Amplify in Eldoret in Kenya, which actually is a consortium of partners dealing with sickle cell in the country. And I think one of the things that has been highlighted from Dr. Inusa Baba and all the other panelists in terms of newborn screening, it's very key that Africa needs to speak as one in terms of how best to implement strategies to ensure that newborn screening programs are actually implemented. I think, as mentioned by the doctor from Cameroon, it sounds similar to how Kenya's perspective is, because you have different programs which are heavily funded by different partners to implement pilot projects or pilot programs for newborn screening. But on to what extent is it being, or rather reaching out to other parts of the countries? And I think it's just the same scenario in Kenya, where we have it's scarcely, or rather the programs are only in certain areas of the country. Data management is also a big issue. No registries. Probably Spark, Dr. Inusa Baba has mentioned, on initiatives for countries to be able to have data in a platform that can be used to provide information in Africa. I think it's very, very important. Knowing your sickle cell status or genotype status is also important. And then another question is, so what platform do we use in terms of having this facility or this services provided? And I guess point of care test opens up a bit of a platform for people to actually be able to be tested, because it's cost effective and studies have been done. I think I've shared something about validation studies that were done on hemotype SC in Kenya in a poor resource setting. It's, it shows concordance with HB electrophoresis and isoelectric focusing. I guess, are there other ways of reaching out to partners who are able to come into Africa and be able to provide platforms which are cost effective, and be able to reach out to patient organization groups to lobby in the government and say, listen, this initiative would actually reduce the number of people, or rather the burden for sickle cell, and also it will improve the lives of the ones who are there. I guess this is something, it's a conversation, and I guess it's a good one to hear different countries and also from different perspectives. And I understand that based on the conversation is that there's a big need. Speaking out is very, very important, but the political goodwill is also key. What are global organizations doing to curb the issue on sickle cell? Yes, NCDs, it's part of NCDs, and there are global platforms for NCDs, but is sickle cell, I think that's the question also. How best do we continue lobbying for that? But I'll end with saying that knowing our sickle cell status is one of the key voices that we need to continue informing people that they just need to know, just like any other genetic condition, and also be in a position to reach out to cell status. So thank you for this.
Thank you, Sam. That's very informative. Selina from Kenya, do you have anything to say about the newborn screening in Kenya?
Thank you very much. What I can say is that newborn screening is not something that is quite common in Kenya right now. There are many programs and many groups that are coming up with the initiatives of starting newborn screening, different clinics, and different organizations too. So this is the conversation that, just like Sama said, we are continuing with it, we are starting with it. And I'm always of the opinion that with newborn screening, it's quite important, but it's also important to educate these young mothers who are coming into the space, so that whenever we meet a young mother who is planning to have a child or is pregnant, let's start educating them about sickle cell. Whether they get a child with sickle cell or not, this is the first level of awareness, so that people from the ground know what sickle cell is, how they can manage it, and also if they get a child with sickle cell, they don't go into spaces of depression or not knowing themselves. But all in all, I believe all has been covered, and I'm very grateful. I'm happy to see everyone, and especially Baba, who gave a very good and comprehensive presentation. Thank you.
Thank you, Selena.
Hi.
And I'm from Ghana. Do you have anything to say?
Yes. Hi, everyone. I'm Dr. Bankas from Ghana. I really enjoyed the presentation from Dr. Mike and then Prof. Baba Inosa. I think that it's important that we think about ways to expand these pilot projects, because I put a question in the chat box that what is the statistical significance of the information we are getting from the pilot project, and what is the birth rate in the facilities they are using compared to the national birth rate? And so can we extrapolate from the small numbers we are doing in these pilot projects, or do we need to expand as soon as possible, because the data we are getting from there is not really statistically significant? So I think that this is an important topic that has been raised, and we need to find ways to expand the scope. Another challenge for me, and the other countries have said it, is that we don't have access to the data. So there have been pilot projects for a number of years, and nobody seems to know the results from the testing that is done. Nobody has the data from it. There are no publications based on it. And so if we are getting huge funds from donor countries and then we don't even have access to the information, then it's also problematic, because the results from these screening projects are going to, or are supposed to, impact policy. We want to explain to government that we are losing a lot of man hours and we are losing manpower because of the social and economic implications of sickle cell disease, yet nobody has access to the data. So then we have real questions that need to be answered about this. And for the point of care testing, I've used some of them in my advocacy in Ghana. We've had a few challenges with them, but then I saw a website link was shared for a study on it. So I'll read up on it and then I'll probably put feedback on the group page. Thank you very much. This was a very, very good presentation.
Thank you.
Thank you. Annie Chantel, you had something to say in the chat box. Do you want to share something more before we give back the hosting powers and finish?
Well, thank you very much, Agnes, and hello, everyone. I'll start by saying bravo to Team 2. It was really interesting session, and I got a lot from Dr. Mike's presentation. Incidentally, there are lots of things he said, and being Cameroonian and having lived in Cameroon for 30+ years, it's strange to hear.
Oh, we can't hear you. Well, we are
Hello?
almost coming to an end.
Hello?
Can we have people turn on their videos if you can? Because we promoted people to be panelists.
Hello?
Sorry. Yes, we can hear you.
Hello? Can you hear me?
Yes.
Yes. So I was saying thank you, Agnes. Thank you, Team 2. I wanted, first of all, to thank Dr. Mike, because he gave so much information in his presentation, and I am a bit surprised because I'm in Cameroon. I've been in Cameroon for 30+ years, and there's some of the details he gave that, as someone living with sickle cell, I didn't have. And from Dr. Mike's presentation, what I could suggest and what I think, if I had to meet somebody within Cameroon's health ministry, I would say there is a big need for all that information to be made public, so that people living with sickle cell to know that there are these services and there is just this much that's there for them. Because it's something that, if I, having sickle cell and living in Cameroon for 30+ years, didn't know all of this, I imagine there are lots and lots of other people who don't even have a clue of the fact that there's screening. Yes, it's only in Yaoundé and Douala, but that information, I tell you, I'm very sure there's just very few people who know it. And thank you to Dr. Inosa. He gave his presentation, made me get a lot of information. I work with families of persons living with sickle cell, and it's always complicated when you have teens or young adults who are about to get into a relationship and they don't know what are their options when it comes to trading between not having sickle cell kids or kids with SS and sacrificing the love. Sometimes I bet you I don't know what to tell them. So that's why some of the questions I had to ask Professor Inosa were on options, just to let these young adults know you can have the love and you can have the kids, because in those days it was you can have one or the other. You could go for the love and miss out on the kids, or you could have the kids and miss out on the love. So you had to choose. But it's good to know that you could be SS and love somebody who is AS and have a chance of having kids who won't be SS and would have normal life being AS. So it's thank you very much, Dr. Inosa. And I think there is a lot that has to be done. A lot of the things Dr. Inosa said, services and data and information that's out there, that somehow I think has to be presented or brought back to the continents or the countries where there is sickle cell. I am based in France, and I see a lot of, I would say, opportunities for people living with sickle cell on their concerning health, well-being, and which back in Africa you don't see it. And I think some of this health data or opportunities or services or projects should trickle back into the continent, be it to Africa or Asia, all of them, so that the populations there should be able to benefit from it. Else, it will be data that is out there, but those living with the disorder and having to care for kids and people with the disorder are not getting it. So in the end, I would ask myself, so where did it all go? What's the end? What's the bottom line? I would say the bottom line should be that people should be able to access this so that it will help make their lives better and make them better people who can then give back to their respective communities.
Yeah,
thank you.
I think that's the most important thing for us. I think that's why we brought this platform. We realize that most of us in these organizations are from an African background, and we see the need that, you know, we have it better here. But in saying that, I'll tell you for sure that also in Australia, we don't have newborn screening. That's something that we're actually working on. And Natalie can come in here. We try to do a survey to ask the people's opinion. What would they prefer if we had to advocate for either newborn screening or prenatal screening? And we got very divisive information. People are saying, what's the point? Why should I, you know, the baby is going to have the sickle cell anyway. Am I going to abort? So those are some of the things that we came across, and we have to do the report at the end, Natalie, and know which direction to go. But I feel newborn screening is something that's really important that we will fight for. There's a process to follow here, and we are working on that. So Natalie, maybe you can speak on that.
Okay. I think I don't know. So we definitely have seen some common themes, whether it's in Australia, even though our population, our survey population is obviously much smaller than a lot of, you know, African countries or countries where it is really prevalent. So we've definitely come to the conclusion that newborn screening at least is a start, you know, at least in terms of early intervention and long-term care. But at the same time, we cannot neglect, it is also a way to segue into other types of screening like prenatal and genetic counseling. Fortunately, in Australia, you do get more a holistic program, you know, where you are, you know, there is greater follow-up. So from the time that a child is identified to have sickle cell disease, there are quite regular interventions and follow-ups, you know, so you do get good care, decent care. But in terms of replicating that to Africa, one thing that I also see, so from Dr. Mike's presentation and Dr. Inusa's, which were really great presentation, and some of the comments that I also took from Enam, from Ghana, as well as Samuel, it's that education has to work with data. You know, we just cannot escape, you know, we cannot escape it. We can talk about this until we're blue in the face, but until we actually have something to present, you know, especially to policymakers who should have the political will and take the responsibility of actually moving this forward, you know, talking about it, yes, will be good. People do need to know about their statuses, but at the same time, you also have cultural challenges that you also deal with. You know, one example that we even hear about is where people think that they can pray away their genotype, which obviously we know is not possible. So you do need that type of, yes, it's good, they know, but you need that type of targeted education and policy driving, you know, to ensure that people really understand and make the best decisions possible. Sickle cell is not a death sentence. Well managed, people can thrive. Yeah, so that will be where I leave it. Thank you.
Well, thank you, Mariama. You are the host. Before we finish, is there anything anybody wants to say? And if can people turn on their cameras if they're comfortable to do so? We get a family photo before we go.
Well, what I want to say is that I must really commend the ASCR organization for, putting together this initiative, putting together like Agnes, Natalie, and the team. I'm sure you guys have a very strong team to actually, be able to pull this thing together, coordinate the whole thing, the whole group chat, everything is always on top. This is amazing, and I must say, at some point, I got really.
I can't hear you properly.
Yeah, just speak close to the mic, Mariam.
Can you hear me?
Yeah, if you move close to the microphone, thank you.
Now, better?
Yeah.
So what I was just saying is that I want to actually first of all commend the ASCR team for coordinating the whole Amplify the Voices of Sickle Cell Disease globally, because this is global. Like you've connected, your team connected on like several people on the group chat, and the communication was very consistent, and the whole coordination was very smooth. This is great. I got emotional at some point during the session because sickle cell is very passionate and dear to my heart, and I've known a lot of people suffering and battling with this disease, and I must say they will feel very hopeful that it will get better, with all this passion behind this work, that it will give a lot of hope, and for the warriors and for the families as well who are behind the warriors as well. So definitely, that's what I wanted to say. And the Gambia team, we're working very hard as well. Ali is doing a fantastic job out there with him and Andrew and the rest of the team as well. And yeah, we're trying as well to see what we can do and make a difference in our communities and the rest of the communities as well, all advocating for sickle cell disease. But above all, this was a fantastic session. Lots of information learned, lots of great things shared between one another, and the questions that were asked as well. And we look forward to greater partnership and working more in teams to achieve the extraordinary. And beyond that, what we learned today, I want to just hear a few lines from the panelists to see how would we use what the information, how would we apply it, how would we apply the information learned and shared today to foster interdependence? And how do we apply these methods to break the silence, which in turn will help break the sickle?
Anyone? Well, for us, I'll come in if the top panelists are still thinking about what they're about to say. As for us, what we've done is just taking it upon ourselves as like this. Of course, we are going to continue providing this platform. And as we know, the people on this session in the group, what we've discussed is what's the outcome, what outcome do we want out of this? At the end of this, we're going to give a report, and where we take that information, we want everybody of us, if possible, take it to our policymakers, to your local member of parliament, to your hospitals, to the people in the community. There needs to be action. There needs to be accountability, as you said. Well, unfortunately, the way things are, where this condition is very prevalent, especially in Africa, there's the resources there, unfortunately, are not as good as how other places are, like this place. So we want to see that, talk is nice, but we want to see some action, and it's up to us. No one is going to do anything for us. It's up to us on this panel and everybody watching. We have to do it ourselves. So at the end of the day, for me, my hope is that we take whatever we've learned, especially from Professor Baba and Mike and everybody who has contributed to this, and try to put that into practice wherever you are. And we continue these partnerships and see how we can even grow further and amplify our voices even more. Let this not be the end. Let's continue doing this even in the future, even next year, so that we continue talking about this and, as we've said, sickle cell disease has been around for over 100 years. And if we sit down and wait for other people to do it for us, we won't. I think it's about time that the countries where this condition is prevalent stand up and don't wait for places like America or Europe to do research and all that. Let's take it up upon ourselves. And it starts with us. It starts with the people that are living with the condition. It starts with caregivers, the advocates. Then we go up and take these countries or the leaders accountable. But I think small groups like this, that's where everything starts. I think my hope is for us to continue this discussion and take it further.
Can I add something? Hello? Hello?
Who's that? You have?
That's Anne Chantal.
Oh, yes,
Hello.
Yes.
Yeah. Just to little thing I wanted to add from Mariam's question. I think sessions like this would go a long way to help advocates have answers with examples to give to those persons living with sickle cell disease or family members or caregivers whom they meet as they advocate or they speak out on the disease. For me personally, this session has given me a lot of information because, as I said, I work with families that have maybe kids living with sickle cell, or some who have they don't have the sickle cell, maybe a parent has it. And I work more with families who don't want to come out in the open. So these families want to stay behind because society has made them feel they don't need to come out in the open. And so they're already blocked. They don't have access to information. And a session like this makes me a kind of middleman communicator. So I get to get the information from the experts. I get to get the examples from other people living out there across the world, living with the disease, on what opportunities are out there, what can they do, what are the next steps they can take, newborn screening, life as a teen with sickle cell, life as an adult with sickle cell, life as a mother with sickle cell, and I pass it on to them so that I kind of facilitate their lives and try to pull them out from that little corner they've hidden themselves and let them know the world is not all bleak. There is some measure of hope. There are things that can be done and they can do. They can access their services that are out there, and they don't need to just stay in their corner and feel all is bleak, so we're already dead. So it's very important sessions like this one, and I think other advocates would find sessions like this one very important, because I bet you it's sometimes difficult to explain from your own life experience if you don't have some other example to add to it that brings that little wow, that little extra to the person you're talking to, because they'll be like, where's she getting this from? But if you can show an example, and I'll go forward to say sessions like this are good, but if we can create these networks, the way somehow if I'm stuck someday and somebody asks me a question, I'm about to marry this guy, he's AS, I'm SS, I don't think I'm going to go for it, I love him like crazy, I would say, oh, a friend of mine, Professor Inosa, said there is this chance for me. And I might knock at Professor Inosa, I might look for Professor Inosa and say, hello, Professor Inosa, maybe on LinkedIn, maybe somewhere, and say, I have this situation, please help. Because these people need some answer, and it's their future, or the future of the children they would have. So I think these sessions are super great. Thank you very much.
Thank you. Well, it's almost 2 hours past, 30 minutes, actually, almost 45 minutes past. We were supposed to finish at 10:30, and almost going into the third hour. So if nobody has to say, we'll have to say good night, good morning. I want to acknowledge Dr. Kenneth Wafula from Kenya, who joined us just right at the end. He will come on to one of these sessions to be an expert. He's a doctor working with patients in Kenya. So Dr. Wafula, if you are listening, your mic is off and your camera. Thank you for joining us. And everybody else who joined us, thank you guys. And we are back next week with Team 3, they've got psychological effects in sickle cell disease. We can't wait. That's a very important topic because all these newborn screening, all these crisis and everything, if you don't heal your mind, there's nowhere you are going. So we feel next topic next week is a very, very important topic that has to be tackled. We welcome you again to join us, and let's talk about mental health. And for me personally, that's why I started this. We started this because we felt an example for me when I started talking about me as a caregiver to a child who was living with sickle cell disease. I felt a sense of hope, a sense of healing. Even I did go to psychologists and they offered me the antidepressants, and there's nothing wrong with taking antidepressants, but it didn't work for me. The moment I started talking, and that was 7 years ago, I just found a sense of hope and a sense of healing. And that's why I said, you know what, I can share this with the world. So I spoke to Natalie and my other members in the team. They said, yes, we can do this. And that's how this started. All this started because we wanted to encourage hope. We wanted to encourage people talking about sickle cell with all the stigma that's attached to it. You know, we are saying no to stigmatization for sickle cell disease, as we've heard over and over again. Sickle cell disease is just a normal disease. There's nothing wrong to shy away. We're not talking about it. We are encouraging people to talk about it. Take action, get tested, look after your health. So next week is a very important topic. We're going to talk mental health. We welcome you to come back. If no one has anything to say, we'll have to wrap up. And yeah, if no one has to say, then we have to end. Thank you so much, everybody, for joining us. We didn't get a family photo. I did get a few, and if people didn't smile, this is your chance now. Can I see them? Arafa, hi, from Tanzania. You didn't say anything. Hi, Arafa. Sylvia, Zambia.
Hi. How are you? It was really amazing presentation that I was wowed, because we don't have newborn screening in Tanzania that common. It's very few that get newborns, like one hospital or two. So we don't have newborn screening.
Okay. Well, thank you so much for joining, everybody. And I've said, for people who didn't smile, just know that I got your photo without smiling. So better smile now. I'm giving you your last chance to smile. I will get off.
But you might ask Zachariah and all the Zacharias to
all the Zacharias. So Zachariah, what have you done, Zachariah? All the Zacharias, please turn your cameras on. Dr. Wafula, yes. Hi, Dr. Wafula. Yes, we can see you now.
How are you? And say hello to everybody.
Thank you. We look forward to you joining us next time on one of these sessions.
Agnes, I'm sorry I joined late, but I'll join you next time.
Okay, no worries, no worries. Thanks for joining.
But I think Selena was online, so I think she did a good job.
Yes, and Sam was, yes, also they represented Kenya. Thank you so much. Thank you for joining. So can we have all the Zacharias, please turn your cameras on. We want to see you.
This has been such an eye-opener. You know, I was just thinking to myself, I'm going to find out if we've got baby screening in Zambia, and I'll give feedback.
So Dr. Inusa Baba spoke about the program they are doing in Zambia, Sylvia. So we'll get in touch with Dr. Unfortunately, we're sorry again, Dr. Inusa Baba had to leave early, but he did speak about the program. They've got a program in Lusaka and in Ndola I spoke about. So they are starting, I know they're starting a pilot program in Zambia. So, but I don't think you've got a national program, but this is when Arise Africa through Dr. Inusa, Professor Inusa, they are coming to us to Zambia.
And just another thing, I did share a link on the, I think it was on the chat, and that is just a link to a world map that actually gives information on newborn screening per country. So from there, you can actually tell whether your country has newborn screening or not.
Okay. Thank you. Before
Hello, everybody.
So the last comment, if you allow me.
I'll get a photo first, Zachariah, before we forget.
Yes, please.
Okay, can people smile and get photos with your phones? They might not get a good one. So smiling. Mariam, you didn't smile. Look at us. Like, okay, Zachariah, over to you and your three other Zacharias.
Yes, yes, we are more. At the end, I thank you, my and just as always, you're inspiring us, guiding us. The most important topic is the screening is something very hard and challenging these days in everywhere. And this is the infrastructure of the comprehensive care for the coming care, the new, the knowledge how to fight and how to defeat this pain. I know screening is the most important today, and the topics covered mostly with the most important. I really appreciate everybody. You were too patient with me. You had 4 Zacarias today. I really appreciate your patience.
No, thank you so much for joining. You're always welcome, and please join us again next week. So we better wrap up. It's almost midnight for us, me and Natalie. Thank you guys for everything. We are back next week. We can't wait to continue this discussion in the group, and we'll leave now. Thank you.
Thank you, everyone.
Thank you, everybody.
Thank you, Facebook family. And if I've seen a few comments in the group on Facebook, most of them have been answered. Yeah. Thank you so much, everyone. Thank you, Facebook family. See you next week. Bye.
Bye. Thank you.
Bye-bye. Thank you.